Maryland is a large transplant center, and we're the fourth largest adult liver transplant center in the country. When I was recruited here, it was in an effort to expand that to children. So we want to think of ourselves not just as a liver transplant center, we want to think of ourselves as a liver failure center for kids. We'd like to see kids early in their process, and even if the child doesn't need a liver transplant, but needs some other therapy, medical or surgical, we're happy to evaluate them and have them here at our center. So there's a couple of categories of liver failure in kids. There's a most common need with chronic liver failure is biliary atresia, which accounts for about 50% of chronic liver failure in kids. These are children who are born more or less without a single biliary outflow tract. They've undergone what's called a Kasai procedure, and these are successful sometimes, but usually these kids will eventually need a liver transplant. We follow them and try to get them to at least 10 kilograms or a year of age before we start looking for livers for them. So we want those kids to have their liver for as long as it is synthetically functioning. The rest of the chronic liver failure problems in children are really orphan diseases like cystic fibrosis, Alagille syndrome, and diseases like that. Just a vast number of diseases that are extremely rare that cause chronic failure in kids outside of biliary atresia. For acute failure, most commonly you find kids have been healthy all their lives. They may get a virus or have some kind of prodrome illness and end up with liver failure. So we have a large adult living donor liver transplant program here at the University of Maryland. We do about 12 adults a year. That, believe it or not, makes us one of the largest adult living donor liver transplant programs in the country. But really, living donor liver transplant is ideal for children. A small portion of the left part of the liver can be taken and placed into a child fairly easily. The vessels are almost size matched, and it's almost a perfect fit. So cadaveric livers in kids are a little different than they are in adults. Most kids are transplanted with what we call a PELD exception, and it's more of looking for a liver for those kids that would be absolutely ideal for them. I don't get a great sense of urgency unless the children are fulminant, and the fulminant children always get preference, so there's always something for them. Livers aren't like kidneys, so if the liver works, we expect it to work forever. So immunosuppression therapy for liver transplant in young children is relatively heavy up front, but most kids can be on one pill twice a day for the rest of their lives, and some kids, about 60% of them, can be withdrawn from all immunosuppression depending on when they were transplanted. When we have kids that are listed, we see them at least once a month, and we build relationships with both their parents and the child to try to build some trust, because it's a really difficult thing to have a kid who needs a liver transplant, and it's important to reassure people that those kids are going to get better and they're going to live full lives, and that's why this is such an incredible therapy. I did my fellowship training in Atlanta. I did 30 pediatric liver transplants in my training. I trained at the largest pediatric liver transplant center in the country at that time. Then I moved to Michigan, where I started the first liver transplant program at the Children's Hospital of Detroit, then I was recruited here. So we've been doing e-visits here. If a referring physician wants to have us evaluate a child, we could get their records sent ahead of time, and we could actually see the child on iPhone, iPad, Android program. It's a secure process. It's confidential. We could meet with both the parents and the child. And sure, some of the tests would have to be done here at the University of Maryland, but we could certainly minimize the amount of visits that a child would have to make here. So e-visits really lend itself to pediatrics, to be able to see someone on the computer or iPhone and not have to have a child's life disrupted with a 2-hour car ride and a 2-hour wait in an office is really an excellent idea for kids. We have an app online that has our numbers. My partners and I are happy to get direct phone calls from that app at any time. I think we all have a passion for liver transplantation and transplantation in general at the University of Maryland. And this program and the team that I work with is incredibly supportive. The greatest thing for us is always that first clinic visit when you get to see a patient who was near death and has made it through with all the support, all the help from the ICU, the operating room, our medical physicians. It's really just the most gratifying thing.